Welcome back to the Dr. Geo Prostate Podcast. Today's episode brings us a powerful conversation between Dr. Geo and Dr. Preston Sprenkle, a top urologic oncologist at Yale School of Medicine and director of the Urology Research Fellowship. Dr. Sprenkle is known for pushing boundaries in prostate cancer care. He's a pioneer in MRI ultrasound fusion biopsy using the Artemis device and a national leader in focal therapy, an approach that precisely targets cancer while sparing healthy tissue. That means fewer side effects and better quality of life for patients. In this episode, Dr. Geo and Dr. Sprenkle explore how focal therapy is changing the game, who it's best for, and when traditional treatments might still be the better route. Let's get into it.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo, where, as you know, is my passion, my intention to help you optimize your prostate health, how to live really well after a prostate cancer diagnosis, whether or not you have a prostate, educate you, empower you, so that you can have better conversations with your physicians about your prostate health. Today's conversation is with the one and only Dr. Preston Sprenkle. Preston, thank you for being on.
Thanks, Gio. Great to be here.
Thank you. Man, we go back a long way. So here I am. I do a lot of the holistic and integrative urology work at NYU. Prior to that, you were a resident, I believe, at Columbia, not a fellow resident.
Correct. Med student, then resident.
And time flies. This is early 2000s. You and I had no kids at the time. Now we have X amount of kids, and they're all grown, a few in college, a few going to college. Time flies, man.
It does. It sure does. It has been a while.
You know, I don't know if you remember. So back then, it was challenging for me. I've had this conversation with a few folks from Columbia from back in the day, with Phil Perazio, who's now at Penn, a few others. And I told those guys, man, it was tough for me back then. I'm talking about 20 years ago. Holistic medicine was still, I mean, it was like, so like, what is it? It's not really, there's no science behind it. No one was talking about cold plunges and all these things, the nutrition, the value of nutrition. The research was scarce. And here I am trying to make a statement, and I would say if it wasn't for Aaron Katz, I would have never gotten the opportunity. He was running the Center for Holistic Urology there. And we did some research, but it was very preliminary at the time. And here we are all these years later, and everybody wants to do something integrative and holistic. So I always remember you guys sharing the space with you guys and having this discussion. I said, man, it was brutal back then. I didn't even know that I could stay in any academic center, not to mention anywhere else. So it's beautiful to spend that time with all you guys back then, and to see where everyone is now, and to see that integrative and holistic urology is a thing. So
it's a real thing. I think there's an increasing understanding. It has taken decades, but there's increasing understanding that it is very important. It's very accessible. I think that's the main, one of the incredible things I'm sure you've experienced is that nutrition, holistic medicine, it's very accessible to everyone, and whereas a lot of these kind of treatments, some of them that you and I will talk about today, may not be appropriate for everyone, may not be available to everyone. It's not quite the cutting edge, but it's very important because can absolutely impact people's lives.
Yeah. For example, one of them is physical exercise. I just had a conversation recently, and it's posted for the podcast, with Robert Newton from Australia. He's published extensively on exercise oncology for prostate cancer. In fact, most of what I do is from his research. And I'm talking about not only guys on active surveillance, guys with advanced disease on ADT, guys with bone metastasis, exercising and doing weight-resistant exercise, and the benefits of that. So we know that it can likely reduce the risk of issues and problems from ADT. For example, men who do weight resistant exercise while undergoing ADT actually can gain some muscle. Wow, that's phenomenal. And that's based on his research. Certainly, I've seen it clinically. But then we're talking about, hey, what are the anti-cancer benefits of exercise, right? Am I ready to make such a claim around exercise? We know it's good for your quality of life while you're undergoing treatment. You have prostate cancer. Is there any anti-cancer benefits? And there's been some studies that have shown that in active surveillance, and then they looked at, well, what's happening? These chemicals, these myokines that are produced that seem to have anti-cancer benefits. Beautiful. That said, I'm the one actually favorably discussing and educating people on how phenomenal urologists are, because we are at a time where there's trust issues with physicians, right? Where patients are confused. They just don't trust that the physician has their best interest. And I'm like, well, everyone I know, and I know I don't know everyone, and I know some bad apples. There's no question. You know them too. Everyone I know in urology are phenomenal, are very good at what they do, and they give you all the options. So I'm always the one, because so many people just want holistic therapies, and then they go to people that kind of confirms their bias. Oh, no, guys, urologists are, they do even a prostatectomy, which is, no one wants a prostate surgical procedure, which there's value there. We'll talk about that. But, it's an art and a skill, the way you guys remove a prostate and put things back together. And honestly, a week or two later, when you go to a good surgeon, they're sort of back to normal once the catheter is out, with some leakage of sometimes not even. So it's phenomenal, the procedure. So I guess what I'm trying to say is to the audience is, listen, holistic therapy, if I do have a bias, is natural medicine and holistic medicine. But you can't throw the baby out with the baby out with the bathwater. I think that's the term. Because, urologists do good work. And so Dr. Sprenkel is one of them. So, all right, so let's get right. I got off my soapbox now, Preston. So let's get to it. What's your approach? So a patient is diagnosed with prostate cancer. Where do you, and more and more people just don't want their prostate removed. I see it all over the place, right? So where do you say, you know what, you're a good candidate for focal therapy, and we could discuss the ones that you do, or you know what, for what you have, we're going to have to remove your prostate. What differentiates the two treatments?
Yeah, it's a great question. I mean, it's a very involved question. I mean, there are a lot of details. I think so they're kind of hard stops. There are some things that would absolutely exclude someone from an ablation therapy, right? Or potentially put them at a higher risk of incontinence with a surgical therapy. And we can talk about that if you want. But I think one of the really important things when looking at all of these and comparing them and trying to make a decision about management is, what do patients want? Like, what are the things that are important for them to really preserve or impact the least? Because anytime that we're doing an intervention, unfortunately, the truth is we're going to have some impact on a man's quality of life. And absolutely, everyone wants things to be totally the same. We don't want to get older, right? I mean, there are a lot of things that happen when we get older as men. Pee as well. Our erections aren't as good. I mean, there are a lot of things that just happen with age. And so any interventions that we're doing to the prostate sits sort of down behind the pubic bone. It's near the rectum. It's attached to the penis. It's attached to the bladder. It's, in a location that is very sensitive. A lot of important functions happen there. So anytime we're talking about doing a treatment for prostate cancer, doing anything to that prostate gland, we're going to have an impact on erections. A man's penis is not going to get as hard, or as the erection is not going to last as long. They're going to potentially have urinary leakage or worsening of urinary symptoms. We have to pee more often, or they can't hold the urine in. And so I think one of my first steps whenever talking to people is trying to understand recognize where they sit as a baseline, which of these things they want to preserve, what are their priorities. I mean, sort of, I think it talks on YouTube now, but cancer control, impact on urinary function, impact on sexual function, impact on bowel health, bladder health. These are kind of 4 things that there's going to be a variable level of impact on each of those depending on which treatment someone chooses. And I think chooses is an important thing because patients should choose their treatment.
That's a great point.
You talk about speaking to your urologist, speaking to different doctors. If a doctor is telling you you only can do one thing, talk to another doctor and just at least get a second opinion that everyone agrees that you really have only one option, because there may be one thing that we think as the treating physician is better for you than others, but you should be the one who's choosing that treatment.
Or even two options, right? So,
Right.
20 years ago, so radiation, well, on one end, it made things a little bit easier.
It does. Oh, no, it does.
Right.
No, unfortunately, patients walk out of the room and you're like, Doc, you made this harder for me. And I'm like, I appreciate that, right? But my point is that you now are more informed to make a decision, and you can think about what fits with your goals.
Yeah. So it's just radiation surgery. That's it. Some people have a take it out mentality. So they just, their personality is a take it out personality. Others like, there's no way. And so then that's it. Two options. Now there's many more.
Right.
Focal ablation, we just got back. We all just got back from the AUA, American Urological Association National Conference. And there was a lot of excitement around focal ablation therapy. It's been around for about a little bit less than 20 years. I mean, I remember 16 years ago, arriving to NYU, and people were traveling to overseas in Mexico to do HIFU treatments and things like that. Mm-hmm. Fast forward, this is the first time where I see a lot of excitement around it. So it seems like it's going to take off, and for good reason. There's great people doing it and so forth. So what is your approach to, I guess, let me get right to it. We all know that Gleason 6, prostate cancer, if you're part of the Scott Egner tribe, why are we even calling it cancer? Though, interestingly, I've seen a couple of Gleason 6s that have high risk on a genomic test. So I'm curious to know, what we do there. But so those intermediate patients, and depending on many things, it's not outside the prostate, many things like that, you can expand on that. Focal treatment might be the right thing to do. I'm interested in Gleason 8s and 9s. So let's say Gleason 8 or 9, PSMA PET scan shows, no, everything is encapsulated. And, from my perspective, I'm not a surgeon, so maybe that's why. But from my perspective, cancer is cancer. Gleason, is a Gleason 9, Gleason is cancer. So ablate the cancer, assuming, based on imaging, there's nothing else outside. So why don't you take us through that process from Gleason 6, perhaps high risk, what will you do there, intermediate risk, and then higher risk, and what will you do in those situations?
Yeah,
take us through that journey.
Very good questions. Yeah, that's a big journey, right? So starting with sort of Gleason 6 high genomic risk. So it's important to recognize, and what that genomic testing is telling us is that not all Gleason 6 is the same. And I do believe that Gleason 6, when it is, and that's when that is the only cancer present in the prostate, does not metastasize, does not spread, is not dangerous, is not going to cause anyone's death imminently in 10 years, probably even in 15 years. The challenge is that even with MR fusion biopsy, we're much better. So we have much more accurate biopsies. But even then, we still can miss some clinically significant prostate cancer. That risk is pretty low. It's around 10%, but it's not zero. So someone who has Gleason 6 and a high genomic risk score, the concern for many people is that, okay, this could indicate that there is higher grade disease that we just didn't detect with our biopsy. I think it's much more relevant in people who don't have access to MRI fusion and they're having a standard truss biopsy. When you have something like that, because we know from the early active surveillance data in men who had Gleason 6 on a standard truss, on repeat biopsy, there's anywhere from a 28 to 40% upgrading rate on the next biopsy 6 weeks later. And so there was a lot of cancer that's missed with just doing a random truss biopsy.
Truss is transrectal biopsies. No, that's fine.
Yeah, transrectal ultrasound guided biopsy, or just a standard kind of ultrasound guided prostate biopsy. And the transperineal,
I was going to say old school biopsies, but it's still prevalent, I think, as opposed to fusion biopsy.
About half of the biopsies are still done that way in the country, we think. Yeah. So personally, because when I'm doing the biopsies in our MR fusion, I use a high genomic score in a Gleason 6 to suggest that we can observe that person on surveillance, but we should do it in a more frequent manner. So probably repeat an MRI and biopsy in 1 year rather than deferring for 2 or 3 years, which we are now trying to do for our sort of lower grade active surveillance patients.
So pause there. I was still under the impression that standard, and again, a lot of my patients say, look, I don't want another biopsy. And I say, well, it depends. But so I was under the impression that it's still a year after the first biopsy. So is that changing now?
So for many practices, it has. My personal practice and what I recommend is the initial repeat biopsy is at 1 year. But many of my colleagues around the country and around the world, if they've had an MRI fusion biopsy as their initial biopsy and it's Gleason 6, will defer that next biopsy to 2 years. I think the key, whether it's 1 year or 2 years, is that you have to have at least one additional biopsy on active surveillance.
Yeah.
We get good information from one biopsy, but it is not adequate to truly tell you what your longer term risk is going to be. We do know that these things change over time. So of men with low grade prostate cancer, grade group 1, half of them will develop higher grade prostate cancer in the next 5 to 10 years. Now, if you're 75 and you have low grade cancer, that's a different story than if you're 50. And so,
or 40. I have a 40-year-old on active surveillance with the Gleason 6. Yeah.
Right. And so I think, the exact timing, like I do it at 1 year 0, year 1, and then based on that, we figure out the timing of subsequent biopsies. We want to decrease the number of biopsies that we do. A lot of us are looking at and doing research, and how adequate is imaging to replace biopsy? Doesn't really seem to be, but it may be in some cases. So, there are a lot of different things that we're looking at because we recognize the burden of biopsy. But yeah, so for low grade, high genomic risk, I personally think it's still okay to observe those people, but I do think the genomic risk is something that we need to pay attention to. And so I follow them a little more closely on surveillance.
Right. So you wouldn't treat them with anything, with focal ablation or anything, unless something shows that is not low risk, as maybe Gleason grade 2.
Correct.
Yeah.
That's correct. Yeah. So my practice, I strongly recommend against it, and largely because if we're treating someone with grade group 1 prostate cancer, what we've seen in our data at Yale and also at other institutions is that the likelihood of finding low-grade cancer on subsequent biopsy, even if we treat that, is 50% or higher. So, so conceptually, I understand to treat it, but if you realize that a biopsy a year later, even if you treat the cancer, you're going to have the same thing, probably somewhere else in your prostate, then kind of what are we doing? Then it's really a game of whack-a-mole, but it's not like an important mole that you're going after, right? We're just kind of doing procedures. They're not really clearly having a benefit to you in terms of cancer control. And even though the ablation procedures have reduced rates of side effects on average compared to surgery or radiation, they're not without the potential to still have problems. And so, really want to try to avoid any intervention if we can. So if it's safe to avoid intervention, I'm a very strong proponent of active surveillance in sort of whomever we can safely do that in.
Yeah, I guess the main point there as well is just for the patient and the listeners, just you can't get lost. That's when problems occur. And I've seen that in my career where, Gleason 6, they don't come back for 8 years, and maybe there was something there already right from the beginning. They come back 8 years later, and then the PSA is in the hundreds. And so then that's a different disease to treat. So just don't get lost and keep with your follow-up visits with PSA tests, MRI testing, and so forth.
Right.
All right. So then we have an intermediate risk, also called Gleason grade 2, 3+4 or 4+3. Does that change your approach? Hello, friends. I just want to give a warm welcome to our next sponsor, Lynx DX. As you know, 1 in 8 men will develop prostate cancer during their lifetime, and screening does matter. But common approaches like PSA testing alone can be misleading and oftentimes is elevated for reasons that are unrelated to cancer. That's why Lynx DX developed My Prostate Scorer 2.0, which is a simple, non-invasive urine test that helps you understand your true risk of having clinically significant prostate cancer. We're talking about Gleason 7s or higher. And PS2 uses 18 unique biomarkers to give you a personalized prostate cancer risk score. The test is accurate, whether your urine is collected in the doctor's office or at home and is designed to help you and your doctor understand what is the next step, whether there is more testing involved, imaging, or a biopsy. Talk to your doctor today to see if MPS 2 is right for you. Visit lynxdx.com, that's lynxdx.com, or look below in the show notes for the Lynx DX link.
At this point, it does not. I think grade group 2 versus grade group 3, still ablating both of those groups. There is some data that with the higher Gleason score, there can be a little bit more. We might need a little larger margin around the lesion when we do a treatment. Definitely grade group 3 is going to have a higher recurrence rate than grade group 2. I mean, we know that's true for someone who has surgery or someone who has radiation. It's just the biology of the disease is defined by that grade group and by that Gleason score. And right now, that's the best thing that we have is the Gleason grade group to really try to define that biology. But no, I think they still are both candidates for ablation. You know, you kind of step into that next group of the Gleason 8, 9, 10 really high risk patients. I do not routinely recommend ablation for people with high risk prostate cancer. I think.
And why is that? Because you are at Yale in a very prestigious academic institution, and if the research doesn't show it, you won't do it. You think there's a real legitimate problem where they can have a recurrence. So this is a patient is saying, Dr. Sprenkle, I'll take my chances. The PSMA is negative. I'll take my chances. And I'm working with Dr. G. You know, Dr. G. Yeah, I'm working with him, holistic protocols too.
Yeah.
So, I know there's a risk.
So again, this gets back to patient choice, right? So my job, I think, is to inform people. And what I can say is guidelines right now recommend against high-risk prostate cancer. Yeah. You know, we're in the process, right? I mean, I'm writing the IRB right now to be able to start treating patients with high-risk prostate cancer on an observational protocol, but still the counseling is going to be the same. Like there is a risk of metastasis. So you bring up PSMA PET scan. Incredible addition to our armamentarium to try to identify prostate cancer metastases and stage cancer. But there are very good studies that have shown that in men with high risk prostate cancer and a negative PSMA PET scan, they're still approaching 20% of men when they had surgery and their lymph nodes removed had cancer in the lymph nodes in the pelvis. Mm-hmm. And so that 20% risk, if we do a focal therapy, if we are doing treatment just to the prostate, we are not removing any of those. And so this is under the presumption that if you're doing a prostatectomy, you're going to have someone do an extended pelvic lymph node dissection. If someone is doing a prostatectomy only, the surgeon is telling me, oh, that's fine, I'm just going to do a prostatectomy, I'm not going to remove the lymph nodes, then yeah, I actually think an ablation is probably as good as a prostatectomy. Or I have patients who are older and they're talking to the radiation doctors and the radiation doctor says, well, you know what, we can avoid the hormone therapy and I'm just going to treat your prostate to like minimize the side effects. I'm like, well, listen, if that's the treatment, radiation treatment you're going to get, then actually I think ablation is probably adequate and similar in terms of cancer control to radiation to the prostate only. I do not agree. I don't think that is the recommendation. That is not the standard recommendation because we treat a young man with high-risk prostate cancer. I would not recommend ablation. I would recommend a surgical prostatectomy with an extended pelvic lymph node dissection. And I probably recommend that over radiation for young men. If they want to do radiation, I think the data is very strong for prostate radiation with targeted boost to the area of the lesion in the FLAIR trial, along with whole pelvis radiation. I mean, the POP-T trial clearly demonstrated a survival benefit when radiating the whole pelvis. Now, that increases side effects, right? So we're increasing side effects, but we're getting better cancer control. And that eventually is the needle that we're going to try to thread with these ablation therapies is how do we get adequate cancer control while minimizing the side effects? And the argument for ablation or for prostate only surgery is that those patients have a very high likelihood of recurring anyway. And we will be able to clean up that recurrence with a combination of hormones and radiation as secondary treatment. And so their overall survival is probably not going to be impacted, but we're giving 50 to 80% of those guys a chance at a cure with an ablation or a surgery alone. So I realize I'm kind of talking in circles a little bit and did a little pirouette there, but the short answer is ablation therapies for high risk disease are not recommended currently by the guidelines or any of the oversight committees. It's a very hot topic. We're talking about it a lot. Yeah. I think in very specific cases, it can be considered. I know Hash Ahmed in London, I mean, he is doing it for small volume Gleason 4+4, 8. That's clearly in a targeted lesion. He's considering it. I think that, it is something to discuss, but it is not currently acceptable. I mean, even ablation therapies are not considered kind of standard of care. There's a lot of interest. I think they are ready for prime time. We're gaining more evidence. We're seeing equivalency in terms of cancer control. That was sort of the bar that we had to establish. And we're now seeing that with 10-year data. So we're getting there. And this is kind of the next frontier, is how do we treat men with high risk prostate cancer who similarly want to maintain their quality of life? Can we win in a small subset of those guys by doing an ablation first with, early salvage with radiation and hormones in those people who fail and need more treatment? Like, what are we losing? Are we losing metastases? Are we losing any length of life? Or they have to have escalation of therapy because of that? And those are the questions that we'll be trying to answer in the future. We don't have those answers now.
And it might depend on the type of focal ablation, which we'll get to next. But let's just say after a focal ablation therapy in general, and what can one do if it fails? Can one get their prostate removed? I've seen it with HIFU, after HIFU. How ugly is that procedure, that surgical procedure, if it is an option? So we know that after external beam radiation, that's a difficult surgery if they need surgery. It's very, clunky and sticky, is my understanding, to use simple terms. Yeah. How similar to that is a focal treatment to radiation, to do a surgical procedure after focal in comparison to radiation?
So I'll start with sort of, comparing it to surgery after radiation, because I think that's been our benchmark. And so doing surgery after radiation is challenging. The planes are sticky. It is hard to do that surgery. Can do nerve sparing to try to preserve erectile function, but it's difficult. The main major concern is a very high rate of urinary incontinence. So it's not to say that we cannot technically do surgery after radiation. I think a lot of people come in sort of saying that. It's not that we technically can't, it's that we don't recommend it because of the high rate of urinary incontinence. There have been some studies recently using robotic surgery with a Retzius-sparing approach in the salvage prostatectomy setting. They do report in that study 80 to 90% recovery of urinary control. So that's much better than the 50% that we associate, but it takes a year to kind of get there. So that's a long time to be incontinent. It's a very slow recovery of urinary control.
A Retzius approach.
Retzius-sparing robotic prostatectomy, yeah.
And we spoke about it extensively with Keith Kowalczyk, maybe several episodes back. I don't have that on top of my head, but Keith Kowalczyk from Georgetown spoke extensively on that, if anybody wants to look that up.
So in terms of then ablation therapies, like salvage after ablation. So I think the first thing to recognize is that with any of the ablation therapies, if there is a recurrence of cancer within the prostate, we can repeat ablation. So we can do ablation therapies multiple times if needed. Fortunately, it's not always needed, but we can. If there is progression of grade or the cancer gets bad enough where we feel like a radical therapy like surgery or radiation is needed, we definitely can do that. After an ablation therapy, surgery can technically be slightly more challenging. I mean, it depends on the size of the ablation, the energy used. Looking at sort of the published literature, Andre Abreu, I think, has a couple papers where he looked at this. But it seems that the impact on urinary continence is not that different than a primary prostatectomy. So the rate of incontinence is very low and similar. There probably is a slightly greater decrease in erectile function. And that kind of makes sense. I mean, most of the time if we're doing an ablation, we are doing it kind of near the nerve bundle or in an attempt to prevent someone from needing something like surgery or causing major damage to their nerves. So there's going to be some stickiness there. And the nerves, quite honestly, are very sensitive. I mean, the reason that we are seeking out ablations in the first place is to try to keep that prostate and nerve bundle in its normal anatomic location and disrupt it as little as possible. I mean, even with nerve-sparing prostatectomy, we're not cutting those nerves. There still is a decrease in sexual function for a while just because changing that milieu, moving them around at all, causes them to lose some function, at least temporarily.
All right. So I'm afraid to get into all the different focal therapies available and what's in the pipeline. So give us an overview. And for the audience, we've done several overviews on focal with Arvind George and Dr. Steve Cianti, even James Wysock. So again, we'll use that as a reference. I think our audience is familiar with somewhat familiar with the different types of energies used with the different types of equipment, the location that one can hit with different type of equipment, et cetera. Tell us what you do. So in your practice, what are the different types of focal therapies that you do, and why do you choose those versus any others?
Yeah, well, it sounds like you've really talked to the experts and covered this pretty well so far, but I think it very much is anatomic and where we are trying to treat, how large. So I usually will talk about ablation as ablation. I think focal is, the region or how much tissue that you're treating, but we can do ablations for large volumes. So at Yale, we currently are using Tulsa, IRE or nanoknife and cryoablation. We'll likely be starting to use some transrectal HIFU as well in the coming months. Each of, in a sense, urologists are plumbers, right? And I've got my tool belt, and it's great to have a lot of tools in my tool belt so I can try to personalize the treatment that we're trying to give to where the cancer is located and what the patient's preferences are. There's pretty good evidence and data that IRE is very effective at cancer treatment and has probably the least, because it's a non-thermal treatment, has a very well-defined ablation border, potentially has the least impact on sexual function, but we need to be treating near the nerve bundle and in a peripheral zone lesion. So that's where I primarily would use that.
Is it FDA approved already, or is it not?
So it is FDA approved for tissue ablation. It is getting a CPT-1 level reimbursement code in January of 2026.
Okay.
Insurance coverage is challenging at the moment. That will hopefully change in January.
Okay. So then IRE, probably if the lesion is close to the nerve bundle, might be a good option.
Right, or across the urethra. So I think those are kind of two areas where it excels. Because of the nature of IRE, we're causing just cellular electric holes in the cells to open up and really kills just the prostate cells. It doesn't damage the connective tissue as much. And so it leaves the nerve sheaths intact, for example. It leaves a lot of the collagenous fibers of the urethra intact. So for lesions or cancers that are very close to the urethra, I think IRE also excels because with the thermal therapy, so cryo and Tulsa, for example, we have a heat or cold sink in the urethra to try to limit the damage to the urethra. But that creates a little boundary of normal tissue around the urethra. So with the IRE, we can actually treat across the urethra, get good cell destruction and good tissue destruction there, and really have not seen any significant urinary urethral complications.
Form of energy used with IRE?
So IRE uses electricity. So it is 2 needles with electricity going between them, or more than 2 needles, but pairs of needles with electricity passing between them. And because of the nature of it, it is being non-thermal. So the electricity doesn't generate heat or doesn't generate much. It has a very sort of finite or well-defined treatment boundary. And with thermal therapies, as with anything, you get close to a hot stove, you can feel it before you're touching the stove, right? So there is a halo, so to speak, of that temperature where it's still causing damage even outside the very high or very low temperatures you need for treatment. Mm-hmm. So for cryoablation, for example, I tend to use that predominantly in the anterior part of the prostate, away from the nerve bundles. Cryo is very effective. It's easy to use in that location. And it's away from the rectum, so decreasing the risk of fistula. It's away from the nerve bundles, decreasing the risk of impotence or decreased erections. And it does, so cryo requires about a 5 millimeter margin. It's great because you can see the leading edge of the ice ball, but you are really getting good cancer kill 5 millimeters inside that. So treating posteriorly, it still is very effective. And actually, Jim Wysock and Herb Lepore recently published their 5-year kind of outcomes, and they've thought with a unifocal treatment, typically in the peripheral zone, they still had very good sexual function preservation, almost 80% in those men. And so I think, cryo in the peripheral zone, still even with that margin, that really shows the benefit of just damaging one nerve bundle, but leaving another completely alone. Phil Stricker is one of the sort of gods of IRE. He's in Australia. He's done hundreds and hundreds of these procedures. He has several papers that show, mid to high 90% recovery of erectile function rates using IRE. And so it's really based on that data. We're looking at ours currently, but don't have quite that experience. So it's great to, look at the experts, high volume centers.
Where's the high volume center in the US,
For IRE?
Yeah.
It might actually be Yale.
Oh, okay.
Yeah, we do a fair number. I think we have some of the longest experience. We started doing the procedure around 2015. So there are some other centers that are very busy now. So I don't know, but we're definitely have been doing this as one of the longest in prostate.
Awesome.
Yeah.
Tulsa Pro, at the AUA, they had a pretty big presence there. Sometimes I look at the booths in the exhibition hall that are bigger and nicer. I say, well, they're doing well. That's just my only method.
Yeah.
But I've looked at their research recently. They're very much into the technology, and it's taken off as well. So tell us what Tulsa Pro is, what kind of energy is used, and who's the right candidate for it.
So Tulsa Pro is an exciting newer technology. It uses a form of high intensity focused ultrasound. So a form of HIFU. We don't kind of call it HIFU because when we talk about HIFU in general, that's a transrectal applicator. And so that's sort of everyone associates that with HIFU. But so Tulsa uses a transurethral applicator. So it's an applicator within the urethra, which has a lot of benefits. And some of the main benefits for that are it actually can then treat the entire prostate. So we can very easily get to the anterior prostate. One of the limitations of transrectal HIFU is that beam can only reach so far. So it is very good at treating jumping to HIFU, transrectal HIFU. It's very good at treating the posterior part of the prostate and can reach anteriorly to a certain extent. But they actually stopped doing whole prostate treatments with it because there was such morbidity, urinary retention. You had to do a TERP before you would do the HIFU, or else everyone was in retention having terrible urinary symptoms. Yeah. With Tulsa, because it's a transurethral, and then getting into more of the technical side, because it is based on MRI imaging, it uses real-time MRI imaging with thermometry to actually track the treatment. You can adjust the treatment. You can do imaging throughout the time that you're doing the procedure. It is, I would say right now, the most precise treatment planning and tracking of the ablation therapies, just because it actually has real-time imaging and thermometry available to monitor and adjust the treatment to make sure you're not doing too much, you're not doing too little for the entire prostate. But the benefit too is you can treat the whole prostate. That's what we routinely use it for at Yale, because we have these other management options with cryo or with IRE to do more focal therapies. We have been using Tulsa a lot for whole prostate treatments. It absolutely can be used for focal. It just kind of depends on access and sort of, the wait list. Like, it's a very popular treatment right now. We have patients who are waiting several months on sort of our treatment schedule. So not everyone wants to wait. They'd rather have another type of treatment, even though Tulsa is very attractive to them.
So if they have, let's just say, for argument's sake, two lesions, whether it's both on one side or one on one side and one on the other, and that's it, you could treat that focally, so not have to treat the whole prostate, or you can treat the whole prostate, particularly if there's many more lesions. Is that a situation that the patient decides what they want after you have that conversation with them? Or they may say, you know what, just treat the whole thing. I just don't want to deal with this again.
Yeah, I think it's definitely a conversation. We kind of use focal therapy as a bucket, and I think, or as an overarching name for these ablation therapies. One of the challenges, or what some of the things that we are realizing, is that the margin of treatment does make a difference. And so we probably need at least a 1 centimeter margin around a visible lesion. Many of us who have been doing this for a while are starting to pretty predominantly do hemiablations, because really the only tissue that you need to spare is the nerve bundle and the urethra. I mean, those are really the functional structures. We can get into it. Ejaculation, ejaculate volume, semen volume, that's a whole nother, can be very long conversation. I would say for anyone having treatment for their prostate cancer, other than in very unique circumstances, there's going to be a decrease and potential loss of all ejaculate volume. I think, that's a whole nother topic. But there was a retrospective analysis looking at Tulsa data and a meta-analysis, and they kind of showed that increasing the amount of tissue that was treated reduced the likelihood that cancer would come back. So kind of to your point, like treating the whole prostate is going to give you a lower likelihood of cancer recurrence. Once you get up to a threshold around 85% of the prostate volume, then you actually start to see a decrease in erectile function. So you can treat a large volume of the prostate without having an impact on erectile function. And so I think
what's the cutoff? Your best guess?
I don't think it really matters a volume. I think what matters is actually being very cautious about where you're treating. And so if you can control and avoid treating the contralateral nerve bundle, ideally both nerve bundles, that's going to give you the best chance at sexual function preservation. And so some treatments are better than with that sort of modeling than others.
How good? So any focal treatment is only as good as the quality of the technology of the imaging that you're using. It sounds like MRI, if you can do an MRI, and it sounds like the only focal treatment available that uses MRI is Tulsa Pro. Is that correct? Currently?
I would say that's commercially available. There are people doing in-bore transrectal HIFU under MRI guidance. I think Bafar Adai at Memorial had a trial where he evaluated that. There are people doing in-bore, so in the MRI scanner, laser ablations. So it's not the only one, but I would say it is one of for urologists, a lot of those other ones are being done by interventional radiologists. That's but right. For urologists, I think Tulsa is one of the few. I wouldn't say it's the only, but it definitely has it is the one that has integrated the real-time imaging during treatment into the planning and monitoring of the treatment that I'm aware of.
So that suggests that you need a radiologist in the room to utilize Tulsa Pro. What's that process look like? Do you need to have a radiologist in there?
So I think it depends a large part on your structure. Our team at Yale is a multidisciplinary team. So we have a radiologist, urologists, a plural of us on the team, an interventional radiologist. So we kind of work together to do the planning, do the treatment, discuss cases. I do not think it's necessary to have a radiologist. For those of us who do a lot of MR-based procedures, including biopsies and ablations, we become very versed in reading and evaluating the MRI. And it doesn't preclude having a diagnostic MRI. You still have that. You still know where the lesion is. But, I have done cases on my own. I know that I have colleagues around the country that are doing Tulsa as a urologist by themselves in a standalone clinic. It's very reasonable, and I don't think is dangerous to do that as long as you have a appropriate understanding and ability to read the MR.
Mm. So back to the question, if I'm a patient and I'm thinking, well, this focal thing sounds great. It's almost like natural medicine for prostate cancer. I want the type of focal therapy that has the best imaging technology so that the surgeon can see things better and treat things better. Am I overlooking it or
that's a very natural conclusion. I think you have to be careful by taking this too far down the road, though. Yeah. So our biopsies, while they are more precise than a just regular ultrasound random biopsy of the prostate, and we do have MRI imaging to show us where the cancer is located, we do not know where all the cancer is located. So I think we can get a little bit too precise, and we can be getting caught in this thought process. Okay, I'm going to be really focal and just treat this cancer. I think that's a little bit. It's giving us more credit than we deserve in our ability to treat the cancer. So as I mentioned earlier, a lot of us are starting to do more hemiablations. I think we feel more comfortable treating a larger margin around the prostate. So the imaging is important. I think that it depends on which technology, but the imaging is important to be able to see the prostate and to be able to plan your treatment appropriately. I think that's really where the imaging is key. Is it is challenging to take 2D images and turn them into 3D, and comparing the fusion between MR and ultrasound, especially if you're doing that in your head, it can be challenging. Doing it with software is better, but even that can be a little bit misleading. So we don't want to be too cute, right? We don't want to feel like, oh yes, we know where this is, we're going to hit it with a dart. Like it is not that precise. I think that it'd be disingenuous to say that we're able to do that at this point right now. But yeah.
Going back to IRE and thinking of imaging, so you're getting really close to either urethra or the nerve bundle, but that it seems like a good approach if the tumor is near those two tissues. What's the imaging there? Again, I'm banking on good imaging to make sure that you're looking at these tissues properly.
Yeah, so currently the imaging that we're using for that is just transrectal ultrasound guidance. So it's evaluating the anatomy of the prostate. That's where we can use either cognitive, so that's the surgeon's sort of, it's called cognitive fusion, and taking the MRI, biopsy, pathology imaging, lining all that up on the screens and sort of localizing where the cancer is on the ultrasound, and then placing the needles to appropriately get that. There are fusion software that can help with that planning. But I mean, one of the benefits of IRE is while it has that precise margin, you can sort of treat through the nerve tissue. And there's some animal data that nerve tissue actually regenerates over time, because where it's, again, non-thermal, it's not damaging the tracts of the nerves. It's just potentially killing the cells, and then they can regenerate. So I think with IRE, we definitely can see an acute impact, but we're optimistic that long term we can see a greater recovery, even if we're treating some of that nerve tissue. There is a company that is trying to help us do that planning. So Avenda AI, they combine biopsy data, MRI data, and use an AI to help generate a heat map of kind of where you can treat or what areas you should be including in your treatment to achieve certain levels of confidence that you've gotten all of the cancer. I'll be honest, like those are never 100%. I mean, even if you treat the whole prostate, like, prostatectomy, we remove the prostate, doesn't mean that we've gotten every cancer cell. So I think we have to realistically set expectations. Like our goal with ablation therapies is to give adequate cancer control while really focusing on preserving quality of life. I mean, and it is a trade-off. There is a higher likelihood of needing an additional ablation therapy. Like if you just want one treatment, the highest likelihood of getting your cancer treated with one treatment is going to be surgery or radiation. It is not an ablation approach. But I think informed consumers, right? Your listeners, informed consumers want to be able to make decisions. And I think that's what we're trying to enable people to do.
Yeah, and I think the future we'll see with the data that comes about, within the next several years, decade, in terms of what's even possible. I think that honestly, I don't even think we scratched the surface yet with focal. I think this year is a big year, and I think it's gonna. I think there's gonna be, not that I think, I know that you all are studying it for more different types of diseases, more aggressive diseases, and I think it's exciting to see, because again, while I say it again, urological surgeons are amazing, and artists, certainly the ones I've worked with, most people are still hesitant to remove their prostate, even though, most people I've seen do very well, even from an incontinence perspective. So yeah, the future, I believe, is bright for focal ablation therapies for sure. Dr. Preston Sprenkle from Yale University Medical Center, thanks so much for being on. Final words, and how can people find you?
Thanks, Gio. This has been a real pleasure. So best way to find me is probably on our Yale Urology website. I am there, and with information, I believe there are also some links there to some additional discussions and YouTube videos to ablation therapy for some talks that I've given to our department and residents.
Oh, beautiful. Preston, thanks so much. Again, thank you for your knowledge, your expertise, your time. You're friendship even. Anybody that I was with at Columbia, Jay Shaw is another one that I had on. What a great guy. Yeah. This guy's more holistic than I am right now, Preston.
Yeah. Yes, he is.
He's more holistic. I never thought I ever see that a urologist that I was involved with at some point is more holistic than me. He is. Yeah. It's unbelievable. So really, great to see you. Thanks for everything and all the work you do. I hope to see you again soon.
You too, Gio. Thanks a lot.
Thank you, everyone, for watching this episode on focal therapy. You got some nice details so that you can better have conversations with your physicians about this if you get diagnosed with prostate cancer. So thanks again for watching. We got more to come. This is Dr. Gio. Much love. Talk to you next time. All the best.
We hope you enjoyed this episode. You will continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more.
If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.